Welcome everyone. Thank you for joining us for today's webinar. Today we are presenting Medicaid Monday, from hospital to rehab to home care, presented by Pierro of Pierro, Connor & Strauss and Nora Barato of EVERHOME Care Advisors. So just a little housekeeping before we get started. If you experience any technical problems during this webinar or have a question you would like answered on air at the end by Lou or Nora, please email us info@pierrolaw.com. At the end of the webinar, a link will be offered to request a free consultation with an attorney. We also kindly request that you take the short Webinar Jam survey that will be sent to you when the session has concluded. Providing feedback helps us plan for future webinars. Now, without further ado, we will turn it over to Lou and Nora.
Hello, everyone. Nora, we need to get you in the frame. You want to scoot over a little bit. There we go. We're very happy to be with you once again for Medicaid Monday webinar. Today's topic is from hospital to rehab to home care. Very often when clients get to the level of an elder law attorney in an elder law firm like ours, they have had some incident, either it be a stroke, a fall, some illness that has put them into what I call the stream of healthcare. And that stream of healthcare, when you are in an urgent situation, quickly turns into rapids and you start heading for the falls. And what we're going to do today is track the process. So from living healthy at home to having an incident that puts you into the healthcare stream to going through the rehabilitation process, the discharge plan, and then creating a plan that will get you back home. And for that, we have both legal issues and social and healthcare issues. And so Nora and I are going to tag team this topic, and we're going to talk to you about each of those as it applies to you potentially. So our agenda for today's call, and again, this is one in a series of Medicaid Mondays. We do them the second Tuesday, or excuse me, what, that wouldn't be Monday, would it? The second Monday of every month. So Medicaid Monday topics that we've already done, we'll give this to you again at the end, but we have covered Medicaid home care, nursing home care, managed long-term care system, use of pooled trusts. So there's a whole list. They are all posted. They're all 30 minutes long. And they're all posted on our website at pierrolaw.com. Today, we're going to take a look at the actual process of remaining independent at home, having a healthcare issue, a crisis, put you into that healthcare stream, and how you can protect yourself and plan to successfully navigate hospitalizations, emergency department visits, transitions within the hospital, discharge planning, again, rehabilitation, and then successfully navigate your way back home. So we'll talk about the discharge planning process, what documents you need to have in place in advance to make this go smoothly and to do it successfully. And then we'll talk about the actual home care transition, looking at Medicaid, the role of our law firm, Pierro, Connor & Strauss, the role of EVERHOME Care Advisors and your care manager, and how technology is now being utilized to make this process smoother, more efficient, and less expensive. So with that, Nora, if you could just give our viewers and listeners a little bit of a progression. And for those of you that don't know Nora's background, I've been working with her for about 20 years now. And for a good part of that, she was with a local hospital where she was for 25 years. And she has really played every role internally in healthcare that we're going to talk about today, from discharge planning through the process of hospitalization, transition planning, and then she set up a program of care management for that hospital to transition people and follow them back home. And now we're lucky to have her working with us here at Pierro, Connor & Strauss and with EVERHOME Care Advisors. So with that, Nora, how does this all work?
Well, this, I have to say, is a topic near and dear to my heart because I've seen for so many years people get caught in this, healthcare crisis, and it's very difficult when you're thrown into a crisis. You have, as Lou said, a major acute event where you fall or you get sick, and you end up into this care trajectory where you're not really sure of what to do and how to do it, and it's a very rapid fire process. So the first thing is, when you end up in a situation and you have a crisis, you usually go to the emergency room, and it's very important that you have an advocate that can really be there and hear, because you're in a crisis and you may not know and understand all that's happening. And in the emergency room, if the very first question that you really need to know is, are you an inpatient or are you an observation status? Why? Because that has an impact on your care and also financially on copays and that. What a lot of people don't know is the word admit. We're going to admit mom. Healthcare doesn't even understand what the rules and regulations are, depending on what their role is. A ED nurse might not understand the ins and outs of what an observation versus inpatient implications are. So it's really important that you look at the paperwork and know what your status is. If you're an inpatient, what is important is that you know on your insurance if you have a 3-day qualifying hospital stay. What is really important is there's a lot of insurance rules and regulations that have to be followed. But two critical components that you really need to know in each setting is the discharge planning process that goes across all care settings for rehab and especially your inpatient hospital stay, and your care team. Who are the players on the team that are making decisions with you and your loved one? Because that's really important. The physician drives the plan of care, and it's important that you're having that consistent conversation with them. And in the hospital setting, your primary care doesn't follow you. It's a hospitalist. And on any given day, those hospitalists change on a frequent basis. So you may not have the same hospitalist throughout your hospital stay.
And Nora, if I could interject there, that to me is one of the primary changes in healthcare, in hospitalizations.
Right.
From when I was younger, and I remember going through and working with my parents and my relatives, even as recently as 20 years ago, the primary care physicians had privileges at the hospitals. And when you went to the hospital, you could be followed by your own physician. And today, it's amazing, but the entire treatment that you received from your primary care physician basically gets cut off when you get hospitalized. Right. And they are trying to improve the ability to access records and to access the primary level of care, to know the patient. But as Nora said, the hospitalists you meet may be covering for a weekend from out of town. Right. They may not even be permanent in that hospital. So you're being treated, or your loved one is being treated by a physician that has never met them, doesn't know them, doesn't have a history of who they were before they got to the hospital. And in my mind, this has given rise to the most critical need for a family advocate, because that primary care physician can't protect their patient. It takes the family advocate now, or a professional care advocate, to follow that patient through the hospital and make sure that the care that they received at home or in the community from their physician continues on. And you see medication errors, you see treatment errors, where things are changed in the hospital from the primary level of care. And you need to be vigilant in your advocacy for everybody going through the hospital system, regardless of age, but in particular for seniors who maybe can't really advocate for themselves.
Right. I think one of the things that's really important is if you have a healthcare proxy or a power of attorney, preferably a healthcare proxy, it's important that you contact them and let them know that you're in the hospital. That's your advocate. If you don't have a proxy, it could be a family member, it could be a neighbor, but it's really crucial that you have somebody that is working with you so that they know what your status is, what level, and then what are your goals of care. This is a time where you really need to be outspoken about what your goals are. I want to go back home. I don't want to go to a nursing home or an assisted living. If that's what your goal is, make sure that the discharge planner and the healthcare team know that you want to return home. Because what's really critical in a hospitalization is mobility. If you're not getting up and out of the bed and able to walk, you get weaker. And we see this time and time again. So talk to the physician about goals of care. Also, you need to know about what your rights and roles and time frames are. Patients have a Bill of Rights in the inpatient hospital setting, and they give you a patient guidebook. And I can't tell you how many people don't read that guidebook, but it's very clearly listed also on the hospital walls, on the units. What are your rights as a patient? And it's to be involved in an active participant in your plan of care. It's also, you have a right to know what your discharge plan is and what the time frames are. One thing that I have to honestly say, and you've seen this, Lou, because you get a lot of calls in the legal practice. My mom's being discharged, and I don't think she's ready to go home. You have appeal rights, and it's important that you know those rights, and it's important that you know that the communication is starting even before your discharge. That should be in the very beginning of the hospital, discussion with your family, your loved one, about what it is that you want, so that the team is very clear on what your needs are. And the insurance, a lot of people say, I have this all the time, is, well, but I'm still not able to walk on my own yet. Well, hospitalizations have really changed. Their goal is to address the acute issue and then to move you to the next level of care with the care that you need so that you can recuperate at home. And that's where people get caught into this conundrum of needing additional support, which is often short-term rehab.
And Nora, on that, they discharge people sicker and quicker. That's kind of the catchphrase that's developed. And that's because of, and let's put it on the table, money. The billing process in a hospital drives the care. Mm-hmm. And unfortunately, we see this as attorneys because we get called in, again, not when everything goes right, but when things go wrong. And what we find is many of the decisions that get made to terminate the acute care stay, to terminate rehabilitation, to move people on, to put them back out into a setting where they are financially responsible for their own cost of care, that is happening more and more frequently because of the expense of that hospitalization. Hospitals, when they work well, are miraculous today. I am an example of that. I went through for a heart surgery, an open heart surgery. I had a quintuple bypass and a valve replacement. I was in the hospital for 7 days. When I went home, there was a clear plan of care, but my hospital bill for 7 days was $200,000. Mm-hmm. And that cost of care, I can guarantee you, whether you have private insurance or whether you're using Medicare and Medicare supplement, they're looking at the cost of that care and moving you on to the next stage where the cost will be less or none at all for the insurances that are primarily responsible. And it's this payment source and this payment system that brings attorneys into the game, because you need the advocate for your personal care, but at times we appeal a denial of Medicare coverage. And when we talk about the rapids and getting into the flow of healthcare, You may go in by ambulance to the emergency department. You may then be discharged to a floor. And the minute you hit that floor, they're planning for you to leave. And they're going to move you on to the next level of care as quickly as possible. And very often, as Nora said, Medicare may give you rights that are being ignored or violated. Your private insurance may do the same. So you need personal advocacy, but at some stages you may need professional advocacy. And we're going to talk in a bit about the team and how that all functions.
Right. One thing that I do want to say is you really do need to know the difference between straight Medicare and managed Medicare, because there's different qualifiers in the hospital stay. If you do need a rehab stay, you really should know whether your insurance, if it's Medicare, you usually require a 3-day qualifying hospital stay. So that's really important because that is going to impact whether rehab is covered or not. If you're managed Medicare, you don't need a 3-day qualifying hospital stay. So that's really important. Again, who you really want to have conversations with early and often is the discharge planner, case manager, because you have to be your own advocate.
And so when we go through this process and you get caught in those rapids, and just coming back here, it's very important to ask questions. And I just wanted to reemphasize that on this slide. The squeaky wheel in healthcare gets the grease. And if you simply allow the system, and it isn't one individual, most of the individuals, Nora, I've found in the system are intentionally good-natured, well-meaning, they're there for the right reasons, but the system doesn't allow them to treat you individually because they have responsibilities to the hospital or to the rehab facility, and it's not you.
Right. And the caseload for some of the case managers is anywhere from 15 to 25. So it's important that they're dealing with multiple families.
So advocate, advocate, advocate.
Right.
And ask questions and demand answers. Don't let them shuffle you along without responding questions. Before you ever get into this situation, it's important to think about what documents you should have. And the healthcare proxy Nora mentioned earlier, everyone at 18 and up should have a healthcare proxy. We do them now for kids going away to college so their parents can advocate for them in the healthcare system. But certainly as we age, we should name the person and the alternates who we want to make decisions for us and to communicate with the healthcare providers as we go through the system. The new document, Nora, is the MOLST, and that's been around for several years, but it really has just become popular and ingrained, and more people have them now than before.
Right. That's really important, especially if you're going across different institutional settings. But that is your guide as to what you specifically want, and it's spelled out, and it has to be signed and reevaluated with your physician on a regular basis.
It is a true medical order for life-sustaining treatment, and it covers DNRs and a whole host of other treatment options. So the medical order becomes part of your chart. It is very binding on the medical providers. So it is a great document to have, and you do it in conjunction with your healthcare provider. So MOLST, yes, but always a healthcare proxy. And from a legal perspective, you want to make sure you have a healthcare proxy with a power of attorney to do finances. Who's going to pay the bills to the hospital? Who's going to get medical records to be able to review the charges?
Right.
Because not every insurance company is billed properly. Not every insurance payment is made properly. So you need somebody who can triage the medical bills for you and the co-payments and deductibles that you may be charged for that hospitalization. And we draft our power of attorney with healthcare powers and HIPAA powers so that they can also get medical records to triage medical bills. You want to make sure you have a will and or a trust. And we'll talk a little bit about this, but with regard to healthcare, we see Medicare, we see private insurance, Medicare Advantage plans, but more and more frequently, those have so many gaps now and limitations on coverage that more and more people have to rely on Medicaid. And many of our webinars have focused on Medicaid. We'll touch on it here, but you need to look at Medicaid as a potential payment source, in particular if you need care outside of the acute care setting.
Right.
If you need a nursing home or home health care, Medicaid is likely to be the only program that's going to pay for it, because Medicare, Nora, does not pay for long-term care.
Right. What's important is if you're transitioning to a rehabilitation facility and you know that you want to go home, a lot of the Medicaid programs, they're the best kept secret. A lot of people don't know about them, and they think that they can access them quickly. These are programs that take a while to access. They're very complicated, and you really need the advocacy of an attorney and a care manager to help you guide you through that process, because you need a short-term plan and a long-term plan. So when you do get to that rehab facility, again, knowing your insurance coverage, have that initial rehab meeting to discuss goals of care. Usually the rehabs are very much on top of this. They do their evaluation and they set a meeting up with the patient and the family to do that. Be clear about what your plan is and what you can afford. If you can't afford to pay privately for care and you want to go home, that's when you ought to be on the phone, preferably, in the hospital. You want to be in touch with your attorney or with a care manager that is going to be your advocate post-discharge. But if you're in rehab, it's not too late. The quicker you call, the better, because as I mentioned, these programs take a long time to get in place. And depending on what your needs are, you may be able to have a short-term home care through a certified home health agency if the physician signs the order. One thing I do want to point out on this slide is it is so important that families understand that the patient actively participate in therapy. A lot of people say, well, I was tired. And if you refuse therapy more than once or twice, then your insurance is going to say, well, they're not really motivated to continue this restorative program. It's really critical that you explain. It's, very important that you actively participate in all your therapy sessions so that your insurance doesn't cut for your rehab stay.
And the financial motivations here can't be overstated, because Medicare is a system under great financial pressure. And right now, the Medicare Trust Fund is predicted to go bankrupt in the year 2026, which is 6.5 years from now. So with Medicare under this extreme financial pressure, the system, if you will, is charged with finding ways to cut costs and save money. And that's why they're releasing people sicker and quicker. Now, within this context, there are rights that individuals have to appeal those Medicare denials, private health insurance denials, whether it be from the hospital to the rehab or the rehab to home, to continue your coverage. There was a litigation, Gimeno versus the Department of Health, the Federal Department of Health, where Medicare was terminating people's rehabilitation stays because they were no longer improving. They called it the improvement standard. And CMS, the federal guide to this and the agency that enforces Medicare, was telling hospitals that if they didn't comply and cut the care, that they would be sanctioned by CMS. But they were applying the wrong standard. This federal litigation went all the way up the court system, and it was determined that the federal government was violating its own rules in how they were instructing these rehab facilities to gauge whether you were entitled to rehabilitation therapy. So if you have questions on that as you go through the system, reach out to your advocates. And if you want to have a good plan in place, don't wait till you're in the hospital. Get the plan in place while you're healthy at home so that you have considered all of these things. Ideally, you have long-term care insurance that's going to help you pay for the gaps in Medicare coverage. But if you don't, then we're going to talk about Medicaid as the one payment source that is there.
Right. And if you do have long-term care insurance, a lot of times some of the the plans have a 90-day elimination.
Right. So you're on your own anyway.
Right. So again, when you're going from rehab to home, it requires significant planning, and that's when you need to get family on board and really look at what family can do, what agencies can do, and it really is when you'll find going back home, it's not a time you're going to really feel good and up to doing a lot of these things that are really needed. There's often no coordination, and services take a while to get started.
So let's just talk briefly on that last slide, Nora, about where the system is here and who are the players. So if you're going from hospital to home, you have a discharge planner,
right?
But what are they going to do to transition you back home in real terms?
Well, a lot of what they do is make a referral to a certified home health agency if it's appropriate. The medical physician has to sign for that. That would be covered under insurance, but it's very short term and intermittent. So you really are left on your own, to your own devices with either private hiring and paying out of pocket, or with family support.
And that certified home health agency under Medicare will come in maybe 3 days a week, an hour or two a day.
Right.
If you need 24/7 care or 8 hours a day of care, it is not going to cover that. Medicare will not provide for that. So then you're talking about private paying for that home care. And this is where a lot of people choke a little bit because they start looking at the cost of care.
Right.
So there's very little coordination for care and very little availability of payment from Medicare or private insurance for care. So then you get to, how do you pay?
Right.
And if you have that private long-term care insurance policy, you want to file a claim. But as Nora said, almost all of them have an elimination period or a waiting period before benefits come in. For Medicare, you get very short-term benefits and very limited. 1 or 2 hours a day, 3 days a week is typically what we see. And if you need to go out and pay for 24-hour a day home health care, Nora, and you're hiring an agency, or even if you're hiring privately, you're going to pay $125,000. We have clients right now paying up to $250,000 a year for home health care.
Right.
Most people can't afford that.
Right.
So what do families do? They struggle through this process. And now we have to talk about Medicaid because it is the payer of last resort, but it has become the middle class lifeline and how people can survive in their homes and still get the care that they need. To get Medicaid, you can only have $15,450 in assets if you're an individual. For a married couple at home, the total couple's assets, $22,800. You'll see there, if you actually go to a nursing home and you need what's called chronic care, then you could get a spousal allowance that is a little bit greater for married couples. But those two home care numbers are frightening. $15,450 or $22,800, and the income levels are not much better. $859 plus $20 set-asides, or $879 for an individual, and $1,267 plus the 20, or $1,287 for a married couple. Again, we have done a webinar on Medicaid home care, and you can go back on our website to see more detail about how Medicaid actually works. But we have home care programs, Nora mentioned them earlier, that are available through Medicaid that will provide up to 24/7 care. And there's a lot of myth out there. There are a lot of false stories out there about Medicaid, what it does and how it works. So to put together a good team, Nora, it's critical at this juncture.
Right. If you don't have that team in place, it really is absolutely critical, because one of the things that is really that I like about EVERHOME Care Advisors is it's our expertise as aging life coordinators. We know the system and we know the ins and outs of the entitlement programs, and we can advocate on that level. And in terms of the legal level that Lou and his team can provide, that combination is very powerful, because if you look at this slide, we're combining and connecting the dots for families on having a consumer-driven plan of care that that older adult wants. And we are the support structure for helping them navigate and guide the care along as needs change, as crises arise. So it really is important that you understand that team for aging in place. That's what we do, and we have been very successful in keeping people in their own homes and stabilizing crisis situations.
So from the legal perspective, we've had care management as part of our practice for almost 20 years now.
Right.
We've had different care managers over the years. And where I got introduced to the care management, now the aging life care professionals, was with my mom's care, who had Alzheimer's. And we tried to keep her at home. And I used a care manager who helped us succeed in keeping her at home. And even though I was an elder law attorney and had resources available to me, there was no way that I could know or do all the things that were necessary to put that plan together for my own mother. And so I became very dedicated to the care management profession and have used them over the years with many, many of our clients because of the value they bring. From the law firm's perspective, we need to evaluate the client's goals and the ability to provide care. What's their home situation? What are their family situations like? And we can't really do that. I used to do that as a young attorney where I had the time to go out and sit at people's kitchen table and have that conversation.
Right.
But it's much more effective for a professional licensed masters in social work to have that conversation because they're trained to solve all of the social and healthcare issues and the social determinants of health, the new buzzword. So that informs us. Then we put together a plan, whether it be private long-term care insurance, Medicaid, advocating for Medicare, creating eligibility for Medicaid, because in home care, one of the things, again, a myth out there that people are misinformed on is you can create Medicaid eligibility in 1 month. There is no 5-year look-back period. We can create Medicaid eligibility right away and get Medicaid home care available to that individual almost immediately. Then you go through the process of all of the evaluations to get the care turned on in the home. Throughout that process, we advocate and we work together with care managers, aging life care professionals, interfacing with departments of social services, the Department of Health, perhaps with the institution, the rehab facility or the hospital, the home care agency, and we collaborate. And that team approach to this is so important. So EVERHOME Care Advisors, Nora, is a new organization, relatively speaking.
Right. And what we do is we go out and do our own in-home assessment. We provide comprehensive recommendations. What we have been starting to do is really incorporate technology into the care delivery, because what we find is that there's shortages of aides and home care. And what we can do is through being proactive with putting technology in the home to monitor the daily routine and the care that's being provided, and have access to technology that in the event that there's an emergency, we know right away that there's an issue and we can respond through real-time alerts. We're able to prevent crises from happening and having hospital readmissions. So again, it's really important that you look at the aging in place, that you need to have the advocacy to help you put that plan together, because it is extremely stressful to caregivers. And what we're finding is that it's harder and harder for people to cope. So we hope that this has been very helpful to you.
And again, in conjunction with the other webinars, we're trying to put together all of the threads that you need to make a tapestry to navigate these systems properly. We're doing them in 30-minute segments. Today was the transitional seminar talking about if you do go to the hospital through the ER or directly and then go to rehab, what are your rights? How do you advocate? And how do you put a team together? And I see your website on there, Nora, for EVERHOME. How would they contact you if they wanted to contact you directly?
They can contact me at area code 518-419-7529. And we do a free consultation. And if you go on the website, You can get additional information at www.everhomecare.com.
And for us, we are at pierrolaw.com. That's our website. And you can go there again to find the other Medicaid Monday webinars. And as I said, we've done them specifically on Medicaid home care, nursing home care, MLTC, how to create a trust to qualify for Medicaid, both from an asset perspective and an income perspective. If any of you would like to meet with us at the law firm at Pierro, Connor, and Strauss, you can just click there to request a free consultation. And we have another one coming up with a relatively new program under Medicaid for those people who can't wait. And Nora, we talked a little bit about the delays through the managed long-term care program. You have different assessments and time that will lag before Medicaid will make aids available. But there is something called immediate needs, which the county administers, where if you have that immediate need, you can get your Medicaid application turned around in 12 days. So with that, we hope to see you again on September 9th, or to hear from you here at the firm or at EVERHOME Care for Nora. And thank you for joining us on this Medicaid Monday.
Thank you.